did residency at Brooklyn Methodist, and then I did fellowship here, and then I stayed on in the Sono department. So I'm going to talk a little bit about just ultrasonography and imaging and the diagnosis of ectopic. And I wish that there was more media in this presentation, and hopefully next time I give it there'll be more. But I tried to put some pictures in there so I don't bore the crap out of you guys. Okay, so like ectopic pregnancy, I'm just going to kind of do a brief overview of what it is, what the diagnostic criterion are, and when it should be on your differential. And then after that, we can go through some images, and then there's kind of a listing of pitfalls of how to screw up and miss an ectopic diagnosis. So we'll go through those, because it definitely happens a lot. And ectopics are, if they're obvious, they're obviously easy to identify, but they oftentimes have very subtle signs, and it's a very bad diagnosis to miss, because the outcomes are really crappy. So if you keep those pitfalls in mind, and then you advocate for your patient, and make sure that you do really thorough workups, you can minimize the chance of missing an ectopic or sending someone home to rupture. Basically, an ectopic is any pregnancy implanted outside the uterus, and I think we all know this from med school, like 97% of them occur in the fallopian tube right at basically at the location of the ampulla. This is kind of an important point, because I think this is why at least where I trained at, why it was like always such an argument to get OB to come down and like actually take care of the patients that we really suspected had ectopic pregnancies, because from their perspective, they only represent a very small percentage of normal pregnancies, and they're in the clinic and they're seeing normal pregnancies, and it's a pretty rare diagnosis for them. But it represents a fairly not insignificant amount of visits to the emergency department for pelvic pain and vaginal bleeding and missed menses. So to us, it's actually not an infrequent diagnosis. There is no way you will go through residency without seeing an ectopic. And during my residency, I saw more than a handful, some of which had really crappy things happen to them. So it's something that I became sensitive about during residency. But you will see them, and like I said, they can be subtle, and you don't want to smooth that out. So they represent about 1 in 80 ED visits for lower abdominal discomfort with a positive urinary ECG. They're frequently missed. About 40 to 50% of patients with ectopics require a repeat visit and a repeat scan before the diagnosis is caught. And they are the largest contributor of pregnancy-related maternal fatality. So when it's missed and things go wrong, it's bad. So I think remember all this from med school too. The risk factors are anatomical abnormalities, prior ectopics. The increased usage of IVF and IUD have really increased the rate at which we see these, particularly heterotopic pregnancies with the IVF. That I think heterotopics used to be something that was super rare, or if you saw it, you'd be pretty happy if you found that. But now they definitely happen with increasing frequency. And then obviously patients that have had tubal ligations or scarring and pelvic inflammatory disease. So most of the patients will not have any of these risk factors. So identifying the risk factors is good, but the vast majority of the time they're just going to come in with a low beta, some vaginal bleeding, and an empty uterus, and that has to be enough for you to really chase down the diagnosis. Like I said, the most common presentation is an empty uterus and a positive urinary ECG, and the majority of patients will not present with this triad from med school of abdominal pain, vaginal bleeding, and a tender adnexal mass. Although it's important to elicit all those things and to do a pelvic exam, the vast majority of the time they're not going to have all of those symptoms, maybe just one of them. And then this isn't really related to ultrasonography, but this kind of happened where I was in residency, and I thought I would point out that I think that oftentimes ectopic, or patients that come in that are women that have lower abdominal pain, their symptoms kind of get minimized by the ED or by the OB service, and we think that if we can identify that if the beta is low, or if we can identify an intrauterine pregnancy and the symptoms resolve, that it's okay to send these patients home without really thorough workups, and it's not. It's not, because you have to really do a thorough transabdominal and transvaginal ultrasound, 100% confirmed intrauterine pregnancy before you've ruled out the diagnoses. And on top of that, patients that, basically Black and Hispanic patients, we have a pretty interesting slice of population here, but they have they have a much higher rate of complications in the management of their ectopic, and they're much more likely to be sent home without a confirmed diagnosis to come back and to actually have had an ectopic pregnancy. So I don't remember the exact percentage, but it was something like 20% more likely. So it's kind of it's a big deal. I just think you should really advocate for your patients. Okay, so now on to the ultrasound stuff. Ectopic pregnancy should be ruled out in all women of childbearing age with a positive beta HCG, like beta or urine HCG, and a complaint of abdominal pain and vaginal bleeding. So that's kind of where you're starting from. These are the non-specific sonographic signs of an ectopic pregnancy, and these are important to remember because the number of times that you're going to actually see a extrauterine gestational sac is only about 20% of, like only about 20 to 25% of confirmed ectopics have an identifiable extrauterine gestational sac. The vast majority of the time, these are the kinds of things that have, and these are the likelihood, the associated likelihoods. But most of the time, like pelvic free fluid is going to be an indicator to you. Obviously, the percentage chance of having a ectopic is going to increase with larger amounts of pelvic free fluid and the combination of pelvic free fluid plus a pelvic mass. This is the thing I was talking about, a tubal ring. This is kind of, that's the like slam dunk. If you see it, you're basically guaranteed that you have an ectopic pregnancy. And if you have a patient that has a positive beta and they have hepatorenal free fluid, with nearly 100% certainty they have an ectopic and or it's ruptured. So that's, when you're doing your fast exam in these patients that have really tender bellies, that is a pretty damning sign if you see that. Okay, so just a little review of the anatomy. I think we all know this for the most part, but I just wanted to go through this. Obviously, intrauterine pregnancies are going to be up here in the fundus. Corneal pregnancies are going to be in the cornua, and then the most common location is going to be ampullary fallopian tube. But you will also see things like it is potentially possible to see things like interstitially implanted pelvics and ovarian pelvics, these can be very difficult to identify because things inside the ovary may be misidentified as a complex ovarian mass and incorrectly, not correctly identified as a as a gestational sac in the ovary. And interstitial pregnancies, you may see the pregnancy, it may look normal, and you may fail to identify the fact that it is actually in the body of the uterus, not in the correct intrauterine location. So those are a few things to be careful of. Okay, so this is just a normal empty uterus. So if a patient comes in and has a beta, a positive beta, and you see this after you've scanned through everything, and you see the thickened endometrial stripe, the fundus not having a gestational sac located in it, and an empty uterus, this should be very concerning. So that's what it's going to look like in long. Usually when you put the transvaginal or the endocavitary probe in with the probe towards the head and aimed upwards, you're going to have the cervix towards the right side and the fundus towards the left side. And in short, it's going to look like this. It's kind of the same thing, you've all seen this before, but now you're in short, you have the right adnexa. If you scan over to this direction, you'd identify right adnexa. If you scan over to this direction, you'd identify left adnexa. There's the cul-de-sac, and here you have thickened endometrial stripe. Also, I don't have a video clip, but I'm assuming you would have scanned through the entire thing and seen that there was an empty uterus as well. So again, if you see these two things, it's not good. You have to advance the scanning the entire pelvis, including both adnexa, and making sure that you cannot identify a extrauterine pregnancy. So this is just kind of where you should be looking. When you have an empty uterus, obviously you really want to thoroughly scan through the adnexa, the fallopian tube, identify the uterine wall, and look for signs of an interstitial heterotopic, and scan through the entire uterus. If you still fail to identify, an obvious ectopic, and the patient has an empty uterus, that's very, very concerning for an ectopic pregnancy that just hasn't been identified. And the OB service needs to be notified. This patient most likely should not go home and should have a repeat scan done. So that's kind of the normal or appropriate elevation of services. So now I'm just going to go through a few pictures of what ectopics will look like and some of the things you may expect to see when using a transvaginal ultrasound. So if you have an obvious ectopic, you're going to, again, it's not video, but basically the uterus is over here, you've scanned towards the left, this is the left adnexa, and you have what could be misidentified as a gestational sac. And so if the person that's scanning hasn't gone through the anatomy completely on their own and know that they're in the left adnexa, Sometimes I've seen people misidentify this structure, surrounding structure as uterus, which I think is terrible because it doesn't look like uterus, but you know, it's possible to do that, and it's possible to mistake this as being a gestational sac. The things that are very different about it in a normal gestational sac is it is not nearly as echogenic, and it doesn't, this appearance of what's a gestational sac here isn't going to look the same as it will in the uterus, and you have to know that you yourself are in the adnexa, not in the uterus. So this is kind of the same thing in the right adnexa. This is a little bit more of an obvious one because you've now identified adnexal tissue and you have an actual extrauterine gestational sac in the adnexa. If you see that, obviously, again, it's confirmed. And this is the rest of the adnexa. Notice that you may have complex ecotextures up there. I don't know if it shows up so well. Yeah, you can have like complex ecotextures up there, but they don't look the same as this very well-defined structure that's an extrauterine gestational sac. And then if you see this, this is fairly obvious. This is a patient that has a positive beta and has pelvic free fluid all over the place, and the uterus is empty, and so most likely this person's already ruptured. But you know, this is, if you see this, obviously your life is easy, and hopefully it'll be, you know, comes down and sees this, and their life is easy too. But this is, like I was saying earlier, is fairly rare to see. Okay. So the other thing I wanted to go through, and I kind of had shown this a little bit, but this is one of the things that I think is fairly easy to screw up, in that misidentifying a complex ovarian cyst for a ectopic pregnancy. The ectopic pregnancy, if you notice, like, it has basically a single structure that looks like a gestational sac, and is not as echogenic as this ovarian mass over here. So this is one of those things where you do need to scan through the entire adnexa and make sure, because you know, ovarian cystic masses are going to be more complex appearing, and they're not going to have this nice kind of rounded gestational sac structure. If you just were to scan through this in a cursory fashion, you could very easily misidentify that structure as a ovarian cyst. But if you are thorough and scan through the entire adnexa, I think it becomes fairly obvious to see that this is an ectopic pregnancy, and it is not just a complex ovarian cyst. The other thing that can be done during identifying an ectopic pregnancy, particularly in the adnexa, is if you use Doppler, an ectopic pregnancy, like any gestational sac, is going to be hyperemic, right? So it's going to draw on a lot of blood flow. So you should expect to see high velocity, low impedance blood flow in an ectopic pregnancy, and you will not see those things in a complex ovarian cystic mass, or you shouldn't see those things in a complex ovarian cystic mass. So that's what that will look like on Doppler. It's called a ring of fire, and I guess sometime when I do an endocavitary study with someone, I'll show you guys how to do that. But it's basically just called a Doppler. Okay. The other thing, you know, kind of another presentation is going to be the interstitial implantation. This picture is basically representing the right side of the uterus. They've scanned through the uterus, arrived at the edge, and a few things that are, or the reason I put this slide up here is I think some of the things that are confusing about this is it's very proximal to the uterus, and it's actually inside the wall of the uterus. So if you cursorily scan through this, you may misidentify this structure as being intrauterine when it is truly interstitial. And other things that should really kind of go off in your mind when you see a picture like this is that this is abnormally close to the wall of the uterus. It should never be that peripheral. And the endomyometrial mantle is very, very thin. I mean, you can see that very obviously it's not thick and appropriate. The appropriate endometrial mantle should be greater than 8 millimeters. You can measure this with calipers. It's very, you know, every resident knows how to use the calipers. This is 3 millimeters, and that is also totally abnormal. So this is the patient that has an interstitial that I think, you know, when I'm pointing it out, I think it's fairly obvious that it's an interstitial, but if you're scanning through things and you're busy on shift, this is a place where I think you could misidentify this as an intrauterine pregnancy. It's a place to be careful. Okay, and then, unfortunately I don't have any more pictures, but I think these are really salient points, so I just wanted to go through them so that you guys don't make these mistakes, or that you're just aware that these are mistakes that can be very easily made. So the first big one is not getting a transvaginal ultrasound because the patient says that they had menses or that the beta is really low. And I know that obtaining transvaginals are a pain in the ass because you got to go get the endocavitary probe, you got to send the person upstairs for a confirmatory study, and it takes a lot of time to dispo. And so I'm not saying anybody's lazy, but the tendency is if you scan through and you don't see things and the beta's low, sometimes people may be dismissive and send this person home incorrectly. So you know, obviously I have never had menses, but spotting at menses I think can fairly easily be confused by the ER physician, and they can be incorrectly reported by the patient. So you have to have kind of a high index of suspicion. And the low beta is not a good thing. That's like, I don't know why when I was a resident, people had this like incorrect idea that a low beta could be consistent with a very early pregnancy and that it was okay. If you have a low beta and you have an empty uterus, that's really, really not a good thing. It's never appropriate, and that low beta is actually very common in early ectopics. So it shouldn't be reassuring, and you shouldn't just let yourself say, okay, this is a very early pregnancy, the beta is really low and the uterus is empty, because it shouldn't be. There should be some sort of sign or something by the time you have, you've identified this on test. Okay. The second major pitfall is incorrectly attributing an empty uterus to an early, this is essentially what I was saying, but like incorrectly identifying or attributing this empty uterus to an early intrauterine pregnancy or a complete spontaneous AB. The vast, a large number of ectopics have very, very low betas. An empty uterus with low beta is not normal, and you need to, if these two things happen to you, you must advance to transvaginal ultrasound and scan through the entire pelvis of the patient. The other thing is, we all know this, but like you can't count something as a spontaneous AB unless you saw passage of products of conception. So that's, like you can't just assume that the person had a spontaneous AB and they have a low beta and everything is fine. Okay, I think this one is actually probably the hardest one because it's very tricky, and I think even people that are very deeply ultrasound trained can make this mistake. So you just need to be very careful when looking through things and very careful when identifying something as a gestational sac. So mistaking a pseudo-gestational sac, which is a decidual cast, for a double decidual sign or a true gestational sac. So if you have an ectopic, it can create a fluid pocket and the appearance of a gestational sac inside the uterus. And that's called a pseudo-gestational sac. And it's really tricky because it looks like a gestational sac and it looks like it's inside the uterus. But it is different in that it is single layered, and this I think can be difficult to identify. A true gestational sac should have a double layer. It should not be a single decidual cast. And this isn't always true, but when you have trouble identifying between whether or not there's a double decidual sign or a single gestational, a single decidual cast, a true gestational sac will have high velocity, low impedance blood flow because it's going to be a hyperemic, hypervascular structure. A pseudo-gestational sac is just a trick, and it shouldn't have any blood flow. So that is one way to rule it out. But this isn't 100%, and I don't really know what to say about that after that, because sometimes you may have you may not see this, and you have to kind of still have a high index of suspicion. So this is a pseudo-gestational sac. I wanted to point out that just like some of the other things, like kind of what I had shown earlier, here the lighting's really bad. One major difference between this and a true gestational sac is this is way less echogenic than a true gestational sac. A true gestational sac should be like, there should be a bright circular cast. You should be able to identify a yolk sac and or a fetal pole. And you'll see, you really should see two lines here. So if you like zoom into here, in a true gestational sac, there would be two casts, essentially two hyperechoic structures with maybe even a small amount of hypoechoic material between them. And that would be a true double decidual sign. This doesn't have that. This doesn't have that around here. So, and it's also just very poorly echogenic. It's less poorly echogenic on the computer, but it looks essentially very faded compared to what a true gestational sac would look like. Okay. The other ones are incorrectly identifying an early intrauterine pregnancy. So thinking that the beta is low and that the uterus is empty and that's okay because it's just really early pregnancy. That's also not appropriate. This one, I don't think we make this mistake that much unless you're just really arrogant, but like these, like I said earlier, these things are pretty hard to identify, those non-specific signs. So if you think that you're like a baller and you're going to go in there and find something and confirm the diagnosis, you could get yourself in trouble. So oftentimes, you may have complex pelvic masses and or small volumes of free fluid that are the only signs of the ectopic pregnancy, and you have to be really vigilant for those things. Okay, and then this is one that is also super important, and I think people don't understand why. And I definitely, when I was a resident, I would just jump to transvaginal during my early years. And this is a big mistake because this is how you miss heterotopics. If you just jump to a transvaginal ultrasound, your view, your scope of the uterus is really tiny. It's a really great probe, you're getting these beautiful images, but you're not looking at the entire uterus. And so, before advancing to transvaginal ultrasound, a transabdominal point-of-care ultrasound should be performed by the emergency physician to scan through the entire uterus and both adnexa if possible, and if body habitus is permitting, prior to advancing to transvaginal. And I didn't have this happen to me personally, but like this happened during my second year where a patient had a heterotopic. They never ended up getting the appropriate amount of transabdominal ultrasound, and the heterotopic wasn't identified. And, I mean, maybe this wouldn't have been identified even if the person had done the scan, but whatever it is, they didn't do it, the patient went home, and luckily they came back, they were ruptured, but they were stable, and everything ended up being okay. But it was a really significant miss. Okay, and then, so this is kind of related to the same thing. If you don't really get a good global view of the pelvis, you could you could see something that looks like a gestational sac and fail to notice that it's like in the adnexa, or that it's in the wall. So you really need to do the scan yourself and make sure that you know where you are on the ultrasound. So when you scan through the uterus, you should have a good idea of if you're like at the fundal aspect of the uterus or the cervical aspect of the uterus. And when you go in short, you should really be able to identify the left adnexa and the right adnexa and know that you've scanned through the entire uterus. Okay, that's it. There is a really good YouTube video from Sonobites that also identifies some more media. Like, so he's got a lot of good pictures in there, so if you want to take a look at what some of these things look like live, you can watch that, and then kind of the rest of the stuff I got from material. Yeah, just that's it.
Question about the Doppler.
Yeah.
So I thought you were not supposed to use the Doppler in an intrauterine because the heat could get rid.
Yeah, I mean, so that is something that gets said. If you're trying to rule out an ectopic, it's totally appropriate to use Doppler. And even though we have always said this, if you go to the actual OB office, they Doppler live babies all the time. So I don't know, like, I don't know. I haven't had a baby, so I don't know why they do that. But all I know is you can use Doppler. Your chance of hurting the baby is basically zero, and or nil. And the obstetricians use Doppler on live babies all the time.
It came out recently because people were, especially like people with IVF, were like buying Dopplers to be able to like listen to their baby like at home. So then they were doing daily, hourly, just like listening to the baby, and so they had to put an ACOG statement saying that this was not recommended, that there's no clear. They don't understand like what the potential consequences could be to like sustained daily Dopplers on development of hearing on these babies. So that was where the statement came from.
I did not know that. That's useful.
Because you can buy them online.
Yeah, I like I said, I haven't had a baby, so I would probably have never done that. But that's good.
Especially
Now I
when
know.
you spend a lot of money, so you want to make sure that they don't get vomiting. These are like every day.
Thank you.
Yeah.